Good afternoon, everyone. I'm Janice Whitaker. It's my pleasure to serve as the Administrator and Education Program Manager for the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing. And today we have another fabulous CGNE seminar as part of our fall series. In collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Health Risk, How Correctional Officers Assess Risk and Understand Health, will be presented by Dr. Kristen Merss, postdoctoral trainee from University of Wisconsin-Madison School of Nursing. Before we begin, though, we do have some disclosures and announcements to make. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. As a reminder, the seminar is being recorded. And if you have a question or a comment for our speaker during the presentation or afterwards, you're welcome to enter that into the chat. You can also raise your hand. That raise hand feature should be at the bottom of your screen, and Jenny will monitor for that and unmute you so you can speak aloud. We do have a post-event evaluation that we encourage everyone to complete. But it is required for RNs seeking contact hours. And the link to that evaluation will pop up in your browser when the session ends at the end of the seminar. Jenny also sends an email within 24 hours to all participants that also includes the link to the evaluation. So you can complete it, promptly after the seminar, or you can get it through the email and complete it within 1 week of the seminar ending. And then nursing continuing professional development certificates will be emailed to RNs that meet all the requirements within 1 month of the seminar. And if you have any questions for us at all, you can always reach out to cgne@psu.edu. So next, I'd like to introduce one of our CGNE affiliate grad students, Takshila Dasani. Takshila is in her 3rd year of her PhD program. She's pursuing research related to cognitive decline and neurodegenerative disorders in older adults. We appreciate that Takshila is here with us today to introduce our speaker.
Thank you, Janice. Christine Merss is a nurse researcher and postdoctoral trainee at the University of Wisconsin-Madison School of Nursing. Christine's program of research focuses on the intersection of incarceration and health, specifically for older adults and people aging in the incarceration system. Christine is particularly interested in strategies to support and improve the ability to staff to work and care for incarcerated older adults, including both healthcare staff and custody staff. Over to you, Christine.
Great. Thank you so much, everyone. So I will just share my screen. And hopefully you see the PowerPoint. Okay, I saw a thumbs up. Excellent. Thank you everyone for being here today as we talk a little bit about health risks and how correctional officers assess and understand risk and understand health in prison settings. So just really quickly, I do not have any conflicts of interest, but this work was supported by the National Institute of Nursing Research under an F31 fellowship award, and the content is solely the responsibility of the author and does not necessarily represent the official views of the National Institutes of Health. And then I also have another acknowledgement that I would just like to read. So the relationship between research and people who are incarcerated has been challenging and has contributed to the dehumanization of people who are incarcerated. And I want to take a moment to acknowledge the impact that research has had in perpetuating and compounding injustices. I also want to draw attention to the use of language. People experiencing incarceration or a person impacted by incarceration is often preferred when describing this population. However, there will be times during this presentation where I use other language that is more reflective of the language that my participants used. I encourage us all to engage in critical reflection in how we think about, work with, and describe people who are impacted by incarceration. So with that, we're going to kind of start with a high level, understanding quickly of what are prisons in the United States. So prisons, as kind of converse to jails, are places of longer terms of confinement. So these are typically individuals who are charged with a felony crime and serve typically greater than 1 year in prison. So when we're thinking about folks that are incarcerated for 20, 30, 40 years, typically that's in a prison setting. Prisons are generally functioning on the state or the federal level. So the Pennsylvania Department of Corrections functions independently from, for example, the Wisconsin Department of Corrections, which also functions independently from the Federal Bureau of Prisons. There are over 1.2 million people incarcerated in state and federal prisons across the United States. We are a world leader in incarceration, incarcerating about a quarter of the total incarcerated population of the world. Incarceration also disproportionately impacts people of color. You can see some incarceration rates in the table presented on the right, and just some of the breakdown of the people who are incarcerated right now in the United States. Incarceration also disproportionately impacts people who are low income and people who have lower education. So for example, persons who have a pre-incarceration income of 41% less than non-incarcerated persons of similar age. And individuals with no high school diploma or GED have a greater likelihood of experiencing incarceration in their lifetime. And this is particularly relevant for us to consider when we're thinking about both healthcare access prior to incarceration. Oftentimes people are not coming from stable employment where they might have had health insurance provided through their employer. Additionally, they may have different levels of literacy and therefore health literacy while they're currently incarcerated. So I was taught as a nurse to teach to the 8th grade level. That could be challenging when we consider that people who are incarcerated tend to have an average literacy rate closer to the 3rd grade level. And so when we're thinking about health teaching, it's just relevant for us to keep in mind. And then just a little bit about Pennsylvania specifically. There are about 38,000 people who are incarcerated in Pennsylvania. A little over 2,000 of those are women. And these are across about 24 departments of corrections facilities. And the average cost per day for an incarcerated person in Pennsylvania is about $183.13. And all of that information was taken from the Pennsylvania Department of Corrections. So prison and health have a pretty strong relationship, and incarceration has been widely described in influencing health and typically having negative influences on health. It has more recently been acknowledged as a social determinant of health, for example, by Healthy People 2030. When comparing the incarcerated to the non-incarcerated populations, people who are incarcerated tend to have higher rates of hypertension, asthma, cancer, arthritis, as well as infectious diseases like tuberculosis, hepatitis C, HIV, and was also pretty disproportionately impacted by the COVID-19 pandemic. And then also, I think coming as a little surprise to many of us, people who are incarcerated do have an elevated risk, an elevated prevalence of mental health disorders, which includes disorders such as depression, anxiety, schizoaffective disorders, but also substance use disorders and other addictive disorders. So when we're thinking about the population of people in aging, it's difficult to think about the population without thinking about their age, because it is a rapidly growing aging population, growing more quickly than in the community setting. So between 1993 and 2013, the population of people that are considered to be older adults increased by about 400%. And trends that we see in the population of older adults generally do not follow trends that are seen in the total prison population. So by that, I mean, even in years where the population of prisons decreased, where there were fewer people who were incarcerated in prison, the population of older adults increased, both in number and in percent. We also know that people who are older adults in prison have unique social and personal needs. So for example, people who are older adults tend to have lower social support when compared to younger incarcerated persons. That can be for a variety of reasons, that their family may have passed away or moved on while they were incarcerated. Could also have challenges with the amount of time that somebody has been distant from their family and that feeling of connectedness to their family who might be outside of the prison system. We also know that older adults in prison have really unique health risks and health profiles. So there's really elevated prevalence of geriatric syndromes when compared to the non-incarcerated population. These include things like hearing impairment. We see elevated prevalence of mental health concerns, including things like depression, again, when compared to the non-incarcerated older adult population. And then the presence of chronic condition like lung disease, but also things like arthritis and other types of chronic conditions that we see in older age. There's also this rising discussion of prison activities of daily living, or PADLs, P-A-D-L-S. And while inclusive of traditional ADLs that we think of, like eating, bathing, dressing, they are also inclusive of prison-specific activities that older adults would be expected to do. So these include things like dropping to the floor, carrying a tray of food, walking while handcuffed, climbing to a top bunk. So things that in a community setting, we wouldn't necessarily have that expectation of an older adult, but in a prison setting, they would be expected to, just because of the nature of the setting where they are, where they're currently in. Concerns with PADLs, again, these activities of daily living unique to prisons, are that we see that PADL disability is higher in general than ADL disability in community settings. PADL disability is also associated with elevated risk for depression and suicidal ideation and kind of decreased overall function. So definitely some major impacts of PADLs and PADL disability, yet prisons continue to be really struggling and challenged with this, with facing the balance between running the prison and navigating these activities of daily living in prisons. Again, just a little bit more specifically about the Pennsylvania population. There are about 10,600 older adults in prison that are aged 50 and older. Generally, researchers and policymakers consider people in prison over the age of 50 or 55 to be considered older adults because of the effects of accelerated aging that causes a biological or physiological age about 10 to 15 years ahead of a chronological age. So rather than the traditionally used 65 to mark an older adult, it tends to be 50 or 55. These 10,000 folks do make up about 27% of the total incarcerated population in Pennsylvania, again, so a little over a quarter of the total population in prison. And Pennsylvania does have 3 long-term care units that help support these folks in their older age. That is much more than many prisons are able to report. And then the average annual cost of medication for a person aged 50 or older is about $3,300, as opposed to somebody who's 49 years or younger, which is a little bit closer to that $2,200 range. When we're thinking about healthcare that's provided in corrections, it's important for us to recall that healthcare in prison, healthcare in corrections, is constitutionally mandated. Failure to provide a community standard of healthcare is a violation of cruel and unusual punishment. And so it is required that healthcare be provided, but how that healthcare is provided looks a little bit different than how it looks in the community settings. So correctional nurses, similarly to other settings, are at the front line of prison healthcare. And this is in some ways even more accentuated than in traditional community healthcare settings. Correctional nursing is a unique setting and a unique specialty of nursing practice. Working in a prison requires a unique skill set that is different than working in other healthcare settings or other settings of nursing practice, in part because correctional nurses oftentimes need to function very independently. They tend to be one of the only or one of the limited providers or clinicians in a specific setting. So they might be caring for multiple hundreds or thousands of individuals who are incarcerated, and there may be no prescriber on site. As such, correctional nurses tend to function off of really extensive nursing protocols which requires really strong confidence in their nursing practice and really high levels of competency in their nursing practice. So interestingly, sort of relatedly, but conversely, correctional officers, while nurses are the front line of prison healthcare, correctional officers are at the front lines of the prisons. Correctional officers are the ones that spend the most time with these incarcerated persons. They're the ones that are in these settings day in and day out, working with these individuals. They're the ones that are on the housing units, that are working with these folks as they're entering, leaving, moving around within the prisons. Oftentimes they're correctional officers can be tasked with administering different educational offerings or different therapeutic or rehabilitation offerings. And in some situations, correctional officers can be tasked with things like medication administration and some other more traditional healthcare tasks. It's also been documented in part because of their higher level of familiarity and the higher amounts of time that they spend with the incarcerated persons, that correctional officers or COs can serve as a liaison between the incarcerated persons and correctional nurses. However, this ability to liaise between these two entities is not well defined and not well understood. So in general, we have kind of a profound lack of understanding of how COs or correctional officers understand and respond to health and aging in the incarcerated population, and how COs and nurses interact. We know very little about these interactions, when they're happening, under what consequences, under what conditions they're happening, what are the consequences of these interactions. And so the purpose of this study was to better understand how COs work with incarcerated older adults. How do they understand these changes in health and aging that we oftentimes attribute to age and to becoming an older adult? And how do COs engage with correctional nurses? When does this happen? How does it happen? What are the consequences? What are the conditions? And so to answer these questions, we used the grounded theory methodology. Grounded theory is a comprehensive qualitative methodology with rigorously defined steps for data analysis and data collection. And as we'll talk about in a little while, these do happen concurrently. It is an iterative and dynamic. It is a cyclical process. It is not linear, like many approaches to research, but rather the data analysis and data collection are co-informed by the other. So for recruitment for this particular study, we recruited both correctional officers and correctional nurses to try and gain a holistic understanding of how these individuals are working together and how they're working with older adults who are incarcerated. So you can see the inclusion and exclusion criteria on the right. They were broad criteria. We were not particularly restrictive with our inclusion criteria because of some challenges and some mistrust amongst research in the prison staff population in general. And then we also recruited nationwide. So we did not recruit from a specific state or correctional system, but rather recruited both officers and nurses from across the United States. So this is just a little bit about the folks that we did, that were included in the study. So we did ultimately end up interviewing 20 correctional officers and 5 correctional nurses. So you can see some of the demographic breakdowns. I would just draw your attention to the security levels, that we had a pretty broad representation across the 3 major security levels. So minimum being the least restrictive, maximum being the most restrictive. And also that we had individuals who were included in the study who have experience working on a special population unit, specifically units that are specifically for geriatric populations or populations that are medically complex. And then we also had correctional officers with experience working in units that were informed by an academic program or units that were specific to mental health and to incarcerated individuals that are impacted by mental health concerns. So a little bit more about the data analysis process. It is iterative and ongoing with data collection, as I mentioned, and is informed by theoretical sampling, which is this idea of sampling on experience rather than sampling on a pre-prescribed criteria. So these are things like when we started to hear and learn through our interviews that the level of familiarity with the incarcerated person, the level of familiarity that the correctional officer had with the incarcerated person really influenced how they worked with that person. We specifically sampled individuals that might have differing levels of familiarity. So that looked like in practice that we identified somebody who had experience working as a medical transport officer. So that person does not have a home or a base housing unit where they work day in and day out. So they don't work with individuals that they would become familiar with in the same way. to try and understand how that familiarity fits into the ultimate conceptual model. The coding process these are all semi-structured interviews, really in-depth semi-structured interviews. The coding process is again, cyclical process of open, axial, and selective coding, where open coding is this process of similar to in vivo coding of breaking apart the different meaning units that are described within the data to understand what it is, what are all these pieces that officers are bringing up when they're responding to the questions. And then axial coding is described oftentimes as the process of reintroducing some coherence. So taking these meaning units that were sort of broken apart during open coding and fitting them together and making some connections between these different meaning units to understand how these individuals are constructing their reality and how they're constructing the concepts that they're describing to us. And then finally, selective coding is the process of understanding the core category, which is that category which is most relevant in the conceptual model or most central in the conceptual model, and kind of piecing everything together. So if we were to think about it like building a brick wall, open coding is the process of taking apart the bricks, taking them out of the packaging in which they came to us. Axial coding is the process of laying the bricks next to each other. Selective coding is sort of the process of laying the mortar in between the bricks in order to build that wall, where in this example, the wall is the ultimate conceptual model. Grounded theory also necessitates memoing, which is the rigorous process of documenting analytic decisions, pragmatic decisions, as well as hunches, which are these ideas of, this seems like it might be relevant, this seems like it might be coming up in the data, but I need a little bit more. I don't quite have enough to be able to say concretely, yes, this is present in the data. So memoing occurs again throughout the analytic process, throughout the data collection process. And all of this is informed by constant comparison, where constant comparison occurs both within an interview, so comparing something that somebody might have mentioned early in an interview to something they might have mentioned later in the interview, but also comparing across interviews, so different participants, and then also comparing what was said in interviews to larger literature, larger understanding of the concept of interest. So this is the simplified version of the conceptual model that was developed. So at the top, we see that the primary goal, this is from the perspective of correctional officers, that correctional officers are assessing for risk. And risk is either dichotomous, no, there is no presence of risk, or yes, there is. Whether or not there is or is not a presence of risk, they move on to assessing the cause of the behavior that they're observing that caused them to kind of think about whether or not there's a presence of risk. And then from that cause, that influences their response or how they respond to that what they saw in either a passive or an active response. And we'll talk about these in a bit more detail. But before we do that, it's important to understand that when we're assessing, when the officers are describing assessing for risk, one of the important things that they're assessing is risk to whom, or the recipient of the risk. So they think about sort of 5 different categories. They described 5 different categories of risk recipients, as we sometimes refer to it. So there's the inmate themselves, so the person that is actually exhibiting the behavior that the CO is observing, the person that's engaged in the action that the CO has seen. There's other inmates, so other incarcerated persons around that person who is exhibiting this behavior that they're noticing or watching. There's risk to the facility, so these are things like escape risk, but these are also things really like physical or logistical risks, like fire or contraband, violation of policy, those sorts of things. There's also risk to other correctional staff. So those can be uniformed staff like other correctional officers or ununiformed staff like correctional nurses, volunteers, other prison staff that might be in the institution. And then finally, there's also a risk to the self. So that's the correctional officers themselves who is actually observing or seeing this behavior. So when they're considering the risk to whom is important when we're thinking about the kind of the next step as we're thinking about the presence of risk. So when there's no presence of risk, there's sort of 4 categories in which assesses the causes. So either the behavior is untrue or it's purposeful, it's a deviation from that person's baseline, it's related to mental health, or it's related to physical health. So this is important because it's important for us to understand that correctional officers do understand that behavior might be related to physical or mental health, but whether or not they identify it as being due to physical or mental health really has a strong influence in how they respond. Oftentimes, when there's no presence of risk, it leads us into this passive response pathway where correctional officers are much more likely to pass off the observation or to pass off the responsibility in responding to somebody else. So whether that's passing off to a clinician, oftentimes a correctional nurse, passing it off to a security supervisor, or passing it off to the inmate themselves. So for example, when an incarcerated man who has complained of chest pain multiple times complains yet again about chest pain, the correctional officer perceived that this complaint of chest pain was untrue or purposeful, that there was not a real concern for chest pain, and so was not perceived as a risk. And so an RN who's telling us the story says, that the officer told the registered nurse, he's not really that sick, referring to the incarcerated person. And so as a result, the nurse let the incarcerated person go back to his housing unit without an EKG. And later that night, the incarcerated person was flown out and ended up having a quadruple bypass. So it shows this relationship that there is an interaction between the correctional officers and the correctional nurses, and that at times the correctional officer's assessment of risk or lack thereof can have really detrimental consequences on how the nurses perceive and respond to these situations that they're seeing. Another example, an officer tells us that if a guy just isn't acting right, or however you want to say it, we fill out this mental health evaluation, and that goes right to our mental health office. So again, this guy's just not acting right. It's not necessarily a risk. There's nothing overt or, that's kind of causing this officer to say like, yep, we have a problem, but there's just something going on that this officer's not comfortable with. And so they fill out this evaluation and they send it to the mental health office, which we would even classify as passing off to the clinician. So they're not necessarily directly engaging with that incarcerated person who's not acting right, but do pass it off to a clinician, and in this case, a mental health provider. On the other side of the story, when there is the presence of risk, it's typically due to three major categories. So we have policy violations, mental health, and physical health. Again, highlighting that officers do see and do notice when it can be a mental health or a physical health concern. One thing I would note is that the majority of the physical health concerns that we saw that garnered a response only fell on the yes side of the pathway. So that is to say that when an officer noticed something that maybe was a physical health change or a physical health concern, it did not fall on that no side of the pathway, meaning that they had a much more passive response to it, oftentimes not really engaging or not really doing anything, or saying to the individual like, hey, maybe if you want to see a nurse, that's your problem. Again, this yes side of the pathway leads us to thinking about these more active responses where the CO will actually engage in an intervention to try and either stop or mitigate the damage or the risk that they're observing, and can also involve a higher level of engagement or a more connected engagement with the incarcerated person that's actually exhibiting whatever the behavior is that the correctional officer is observing. So whether that be asking questions, whether that be providing some sort of assistance, that they do actively engage with that incarcerated person, as opposed to passing it off to them saying, this is your responsibility to write to the nurse. So some examples of this, a correctional officer says, I did talk to mental health and I just said, hey, this is what I'm seeing. I did a suicide assessment. I'm not necessarily seeing that as far as the score goes, but there's some flags there that I'm, not comfortable with. So in this instance, even though the policy says that the CO is to do a suicide assessment and they receive a score, and that score is dichotomous, yes, this person is at risk of suicidality, no, this person isn't, even though this person scored negative, that they're not a risk at this current time, this CO is still assessing a risk that this person, there is a concern that this person might be potentially in harm's way, or that there might be something else going on with this individual. And so they actively intervened by calling and engaging with their mental health provider team to say, like, this is a concern, this is what I'm seeing, and to really clearly express those concerns to the mental health care team. Another example a CO provides is, so, you have this inmate that has chest pain or an overdose, you'll take them up to medical, or else the nurses will actually come down to the unit and they'll look at the inmate and they'll determine right there after they call the doctor if he needs to just go up to medical or does he need to be shipped out to the local ER. So again, we're seeing that when an officer sees something really concerning like chest pain or an overdose situation, that they will either take that individual up to the nurses or have the nurses come down to actually to assess that patient. So again, working with that intervene and at times engaging with that incarcerated person when appropriate, to make sure that the necessary next steps are being taken in order to mitigate some of that larger risk that we're seeing related to their physical health in these instances. So again, this study did seek to understand how correctional officers understand older adults and work specifically with older adults. And largely, unfortunately, older adults were not particularly mentioned. They weren't necessarily identified as a unique population by correctional officers with unique health needs. And this oftentimes was present even on units where individual or officers were working on geriatric units or working specifically with units for older adults. When they did think about older adults in the context of their work as a correctional officer, they perceived older adults as being less likely to engage in difficult or risky behavior. So the types of things that they're seeing from the older adults are less likely to be that intentional, that purposeful behavior. So for example, as CO reports, they being older adults, they just don't want to be bothered. They want to do their time and they want you to leave them alone. So indicating that these, describing that these older adults tend to make fewer waves or sort of go about their day and not want to have the same kinds of interactions, the same frequency of interactions with officers. They're less likely to be purposefully engaged in difficult behavior. So if somebody is seen to be doing something that maybe would be perceived as concerning or risky in a certain population, might be just be seen as somebody being difficult. In a younger adult, in an older adult, it might garner a different response. And oftentimes this is seen as less risky. And so their officers change the way that they work with these folks. So for example, this officer says, if you see this old guy walking around hunched over, there's an alarm going off, I'm going to make the assumption that he can't hear anything versus, let's say, some young healthy guy who's just running around. I'm like, there's an alarm, you're not supposed to be moving. In this particular institution, when an alarm sounds overhead, all individuals are supposed to drop to the floor and cease to move. So what this officer is telling us is that when if there's an alarm going off and they see an older person, they are more likely to assume that older person is not dropping to the floor because they didn't hear the alarm, as opposed to a younger person. They're going to assume that their lack of compliance with the policy is due to purposefully engaging in that risky behavior. And that these differences really result in different consequences, where with the older adult, they might, flag the person down, inform that there's an alarm going on and help them to follow the policy, versus with a younger adult, it would be more likely to result in disciplinary action or other consequences for the individual. And then again, a large part of the study was to look at officers and nurses together. So in large part, correctional officers rarely mentioned correctional nurses, even when we were talking about health and health-related things. If officers mentioned nurses, they described that nurses can be viewed as a resource if the nurses are present and the nurses are available. So for example, an officer describes to us, you might mention it to a nurse or something if you see her, be like, oh, hey, Jimmy over there told me the same story 15 times in a row this week. So again, this officer is noticing that this person, this, Jimmy, hypothetical Jimmy, is being repetitive, is, potentially showing some changes in their behavior by repeating the same story 15 times in a row. But they would maybe only be likely to tell a nurse of this change in behavior if the officer sees the nurse or sees that individual, sees the nurse on the unit or has some sort of other interaction, kind of preceding interaction with the individual. Officers also described being really discouraged by interactions with nurses, which then prevented future interactions with nurses. So usually, this officer describes, but usually they, being the nurses, don't do nothing about it unless the incarcerated person brings it to their attention, which is sort of interesting when we think about our pathways that we just described. And on the no to the risky side of the pathway, one of the common responses was to pass it off to the incarcerated individual. And so one area of kind of future research that we want to look into is when do we pass things off versus when does the officer more actively engage? But this relationship between previous interactions with the nurses and future interactions with the nurses, the likelihood of engaging with them in future interactions, was pretty clearly described, that when the officers don't feel like they're heard when they're listened to, they're less likely to bring things to nurses' attention, especially if it's something sort of proactive, or I'm not sure if this is a concern, I'm not sure if this is a problem, it's just a change that I'm seeing. So we're going to spend our last about 10 minutes or so just with some kind of high-level discussion and conclusions, and then we'll have plenty of time for questions. So ultimately, this was described by officers. It's described in the literature that the role of correctional officers is to maintain the safety and security of the institution, and by doing that, they assess for risk. And this assessment for risk is constant, it's continuous, it's from the moment they walk into the institution to the moment that they leave the institution. And that was really pervasive across the interviews that I conducted with correctional officers. And interestingly, was also mirrored in many of the interviews that I did with correctional nurses when they described the roles of COs was to maintain the safety and security of the institutions. We also learned that security level and the facility culture influence how correctional officers respond to their observations. So for example, in maximum security prisons, these higher security, more restrictive prison settings, we learned that correctional officers feel or perceive both a physical wall between themselves and the inmate, but also more of an emotional wall between themselves and the inmate, and that wall hinders their response or hinders their likelihood to respond to something. Compared to in a minimum security institution, correctional officers don't perceive that same level of separation from the incarcerated population that they work with. And so maybe are more likely to respond to the observations that they're having of these older adults when they're incarcerated. Health events in prison, so health changes, health events, they can be identified by the correctional officers if the CO has a certain level of familiarity with the individual and if that observation is perceived as risky. So when somebody has less familiarity with that individual, the health change or the health event that they're seeing has to be more emergent and or more visible in order to garner a response from the correctional officer. Conversely, when the officer has more familiarity with that individual, the health change or the impairment can be less emergent or less visible in order to garner a response from the correctional officers. So an example of that is a correctional officer described to me noticing when somebody who had been on their unit for about 10 years didn't come out for breakfast. So this guy always comes out for breakfast. He takes a shower at 6 a.m. He comes out, he eats breakfast, and he just for 2 mornings in a row, he didn't come out and eat breakfast. And so I poked in there and said, hey, what's going on? And engaged with him to see what was happening. That type of change in behavior of not coming out for breakfast is subtle, but could be really important and indicative of some sort of a larger going on. In this particular instance, it ended up that this person's son was hospitalized and they were having a lot of kind of outside of the prison personal things going on, which was influencing their ability and their willingness to leave their cell in the mornings. But again, that importance of that familiarity with the officers to the individuals is really important. It's also important for us to consider in this larger context of corrections, where I'm sure if anybody has read anything about prison staffing in the news, we know that many prisons are really severely understaffed. And so correctional officers are working with higher numbers of individuals. There's the ratio of officers to incarcerated persons is growing, as opposed to in previous years and decades. One officer that I interviewed described that initially when he started, it was about 1 to 25, one officer per 25 incarcerated individuals. And by the time he left, it was closer to 1 to 200. And so we can think about the impact that those different ratios would have on the correctional officer's ability to notice these small, subtle changes that might really be having larger, more profound impacts on an individual. And then lastly, when correctional officers have an infrastructure for responding to their observations, that infrastructure was oftentimes utilized. However, what we saw in one of the examples is that pathway for documenting or to connect with the clinicians was oftentimes in the mental health side of the pathway. So when somebody noticed that somebody wasn't acting right, and so they filled out a mental health evaluation and sent it to their mental health team, similar pathways were not described for the physical health side of kind of the healthcare spectrum. So if somebody noticed, I noticed somebody was limping and they weren't limping before, there's no mechanism for that officer to document that and send that information to the nurses besides a much more active response, like picking up the phone and calling the nurse. And so we did see though that when these pathways are present, particularly on the side of mental health, they were utilized and the COs did perceive them as being really helpful and really well functioning, and were seen as a tool for communicating with the clinical team. And then correctional officers just kind of across the spectrum feel barriers to reporting health and age-related changes. So one of the barriers they felt is this focus on security rather than health. So in institutions that are for older adults or individuals who are medically complex, that focus remains on security rather than health. And so officers felt a sort of dissonance between these two foci of security and health, and not understanding how to marry these two different foci in order to both meet their needs and maintaining the security, but also to meet their needs and maintaining, you know, kind of addressing the health and responding to the health and age-related changes of the older adults. Some of the barriers also included a distant relationship with the nurses. Like we described, the nurses have to be present and available in order for the officers to really feel like they're able to connect with them. We also know when we think about prison staffing that there's high levels of turnover in correctional nurses, like we see in other settings, but the rates of turnover are typically a little bit higher in correctional settings. And so when officers describe that they have a relationship with the nurse, that they know the nurse, that they know that the nurse is competent and that she will, the nurse will respond to their concern, they will engage with that person. But having these distant relationships, oftentimes with newer nurses or nurses that are transitioning, newer to the prison nurses or nurses that are transitioning with more frequency, they don't feel that same strong collaborative relationship, and so feel that as a barrier to reporting their observed, health and age-related changes amongst their older adult population. And then just sort of generally, there's a really pervasive lack of health knowledge. So officers would see that somebody, was telling the same story 15 times, but didn't necessarily identify that as a potential cognitive change. They just thought the person was being repetitive. Officers described somebody being lost in the prison, somebody who had been incarcerated in a prison for a long time, and was in one part of the prison looking for a different part. And the officer's like, well, what are you doing here? That's way over on the other side of the institution. And that person was like, whoa, sorry, didn't realize that. And so that person, the officer just sees that as sort of an old person being confused and doesn't necessarily see that as a cognitive change. So that lack of health knowledge was pretty pervasive, particularly when in the context of these geriatric syndromes. When an officer did describe having health knowledge or aging or knowledge of aging and sort of the aging process, it largely came from previous experiences. So we did interview one correctional officer who had previously been a CNA. And so she described really differently how she perceives and responds to individuals, to older adults who are walking more slowly or who are a little bit more confused, or who are having trouble eating. And there was a pretty stark difference in how other officers who didn't have that previous CNA experience described working with these same individuals. Additionally, a lot of these previous experiences came from working with family members who they had served as a caregiver for in their aging, as they were aging. So one officer described, when I was working with somebody, I always try and think about like, well, I took care of my grandpa, and how did I take care of my grandpa when he was living with me. And I try to treat my incarcerated persons that same way. And then there's also a lack of structure and resources for officers to be able to report what they notice. And some of this it kind of stems back to this focus on security rather than this focus on health. Now, they have really clear pathways for communicating security risks or policy violations, but they don't have the same clear pathway for reporting health or age-related changes. So sometimes there's policies like, for example, individuals are supposed to be handcuffed with their hands behind their back. Well, if it's somebody with a walker, they need their walker, but they can't use their walker if their hands are behind their back. And so officers would violate the policy and shift the person to be able to handcuff to their waist chain in front of them, so they're able to manage the walker, as opposed to having their hands handcuffed behind their back. And then I just want to talk a little bit about the implications for nurses. And this includes both nurses working in these correctional settings, but also nurses working in community settings. That nurses working in corrections are working also in a setting that is focused on security rather than health. Prisons are built to retain people, to confine people. They're not healthcare facilities. And so they're also working in this institution, in these settings where non-healthcare workers are on the front lines. So when we think about other settings as a registered nurse, I think about how the CNAs that I work with are such a resource, such an asset to me in helping me understand the condition of my patient, because they take so much, they're so much more hands-on generally with the patient and spending more time at the bedside than the registered nurse. But in prison settings, it's not typically a CNA who's spending that extra time with that individual. It's a correctional officer who likely has very little to no healthcare training. And so how do nurses have to think and adapt how they practice, how they gain information, how they get information from their colleagues, from their coworkers, in order to have a holistic understanding of these older adults when they're in prison. And then again, the implication for the nurses is that COs, again, these people on the front line, have this notable lack of training and comfort with health and age-related concerns. And again, this was pervasive across both the geriatric units, these units for older adults, as well as on the general units, the sort of general that we think of, the more traditional prison units. And so nurses not only have to work with a population where the person at the front line is a non-healthcare worker, but also where this non-healthcare worker has a really self-described lack of understanding and training and comfort with health and age-related changes. And then it's also important for nurses to remember and to keep in mind that previous interaction with nurses influences the future interactions with nurses. So if an officer brings up something that maybe seems superfluous or seems silly, it's important for nurses to take that seriously and to engage in that as an opportunity to work with that correctional officer to understand the situation. So either why it doesn't garner a response from the nurse, why that person doesn't need to be called up to health, to the health services unit, or conversely, why maybe we should have addressed this a little bit earlier, why maybe we should have talked about this yesterday instead of today, or why we should have brought this to the nurse's attention sooner. So these previous interactions influence both the likelihood of the correctional officer, engaging with the nurse, but also the types of response that officers engage with the nurse. As with any study, there are limitations. So we were not able to include any incarcerated individuals in this study. And so there's a pretty notable lack of one really important perspective when we're thinking about this relationship between officers, nurses, and older adults. The other thing that we noticed is that officers who recruited in the study and who participated in the study were the types of people to describe going the extra mile to improve corrections. And while we wish it were true, we wish this weren't true, this is not necessarily representative of every single correctional officer that works in every single prison across the United States. And so there was a significant lack of inclusion of correctional officers who don't feel that urge to go the extra mile, who don't feel that urge to treat the older adult that they're working with the same way that they treated their grandpa, because that's how you treat your older adults. So really lacked perspectives from officers who were not as empathetic, who did the bare minimum, who did not respect the incarcerated persons that they worked with in the same way that my participants did. And while these people were described by my sample and by the individuals who did participate in the interviews, there is a limitation in not actually having been able to talk with those folks. And then lastly, we were not able to utilize any observational data collection. Again, this is in part due to having a nationwide sample, which came with its pros, but one of the cons is that we weren't able to use this observational data collection. And so there were times when officers were, and nurses as well, principally officers, were not able to describe their processes. So when we would be having a conversation, they would be describing something to me, and when I would try and unpack that a little bit, they weren't able to kind of unpack or describe why they engaged in a process a certain specific way. I just want to take a moment to thank my funders again, NINR. This was funded through an F31 Fellowship Award, as well as a Research and Scholarship Award from the University of Wisconsin-Madison School of Nursing. This was my dissertation study, and so I do want to take a moment to acknowledge my dissertation committee, particularly Susan Loeb from Penn State, who was an extremely helpful and influential piece of my dissertation committee. And then also to acknowledge my participants, who oftentimes were having conversations that they were really uncomfortable with, or that were really challenging for them to have. And just, I wanted to just raise that appreciation of them kind of stepping out of their comfort zone in order to talk with me about these topics. All right, and I think we've got about 12 minutes for questions.
Well, Kristen, thank you so much for that amazing presentation. I learned so much, had never heard the term paddles before.
Oh.
That's really fascinating to think about activities of daily living that would be unique for older adults in a correctional setting. But certainly what a very interesting study and and it really highlights the complexities, I think, of healthcare for older adults in the correctional setting. So thank you so much for sharing that. One question I had, and certainly I'm encouraging participants to put any comments or questions into the chat. You can also raise your hand and Jenny will unmute you and you can share aloud. But we're lots of positive comments in the chat, Kristen. Excellent presentation. That was great. Thank you. Great presentation, and navigating health and security is not easy. Susan Loeb says, bravo, Kristen. So proud of you. Very interesting. Thank you. And excellent presentation. So one thing I wanted to ask you about to get us started with the Q&A piece was, and I may have missed this, but I was wondering if you could tell us a little bit more about the recruitment process. How did you recruit participants for this study?
Yes, so thank you for that question. So because we didn't recruit through one specific correctional system or one specific state prison system, we did recruit nationally. So typically that happened at through professional organizations, through conferences, so connecting with individuals with, that when I would attend different correctional related conferences, and which was really helpful in kind of identifying people who might be interested in participating. And then we also utilize a lot of snowball sampling. So talking with individuals, oftentimes, again, this is really closely related to this idea of theoretical sampling or sampling on experiences, that at the end of an interview, I would ask a participant, so say, do you know anyone who, does X, Y, Z, or who maybe does this or that, or who might have this kind of experience? And they would say, oh yeah, I do actually. Here's their phone number. Let me connect you with them. And so kind of the participants themselves were able really nicely to connect. And that was both participants who were parts of larger correctional organizations, but also individuals kind of through their workplace, or through their personal networks.
Thank you for sharing that.
We
So
do have
Sarah
a hand-
Songer says, Penn State has a number of programs for institutional and past incarcerated persons. Is this presentation available to pass along? We do record the presentation and we put it up on YouTube, so it's available in that way. Maybe Jenny, you can speak as to how people can access the YouTube.
Yes, so we do post all of our recordings to YouTube. We have a CGNE seminar series playlist. It's through the Penn State Ross and Carol Neese College of Nursing YouTube channel. If you attend any of our seminars, the email that you get 24 hours after the seminar occurs includes the link in that email. But you can also just search on Google Ross and Carol Neese College of Nursing YouTube page and find it through that.
Thank you, Jenny.
We do have a hand raised as well, Kathy
Okay.
McQuaid. Kathy, if you would like to unmute yourself and ask your question.
Kathy, you can unmute if you're able to do that. Are you able to unmute her, Jenny, from your end?
I can ask her to unmute,
Okay.
which I did, but
All
not
right.
sure
While
if
we're
it's
waiting
saying-
for Kathy to unmute, Diane Barish does have a question in the chat. Are there any data around potential differences between private prison contractors versus governmental run facilities?
Yes, that's a difficult question. So like we mentioned at the beginning, prisons are typically run either on the state or the federal level. So within both of those, we have public prisons, so prisons that are owned and facilitated by the state or the federal government, or private institutions that are run by a private prison company. There is a small, we know a tiny bit about differences and similarities between private and public prisons. We don't really know very much about them. Doing data collection in prisons is extremely difficult, which I'm sure Dr. Loeb and other individuals who have done research in correctional settings can speak to. And doing research in private prisons tends to be even a little bit more difficult and to kind of face some additional challenges when compared with other institutions. So we don't know a whole lot about the differences between private prisons and publicly owned prisons within the prison systems. But there's definitely a lot more that we would like to learn related to those differences. And then just sort of, I'm just going to kind of build on that just a tiny bit more, that healthcare in prison. So, while we talked about nurses are at the front line of healthcare, however, we also know that prison healthcare can be administered by either like state employees, so individuals who are employed by that state or by that institution, or what have you. But they can also be part of staffing agencies or privately owned, typically nurse staffing kind of structures. So a correctional nurse may or may not be an employee of that Department of Corrections or of that state or prison or federal system. And so it's just we don't know very much too about the differences between the nursing care that's provided or the relationships that are provided by nurses that are part of a staffing agency as opposed to state departments of corrections. I did have one or two participants who a little bit alluded to that a bit in their interviews, with one participant, a correctional officer, describing that before they were part of a staffing agency, he felt a lot more continuity and felt a lot stronger relationships with the nurses that were working there, because there was sort of this, we're in it together, we're both employees of the same place sort of vibe, sort of relationship that influenced how they interacted. When that institution switched to a staffing agency, that we're in it together feeling shifted and changed. Now, we can't say that that's because of these nurses working for a staffing agency, but it is sort of an interesting point that was brought up that I would like to investigate a little bit more, thoroughly in the future.
Yeah, and we certainly see that same kind of phenomenon in long-term care. That sense
Absolutely.
of when you have consistent employees, there's almost like a family-like sense of, connectedness between employees. So you gave amazing statistics and background on older adults in correctional settings. Can you comment a little bit about how that relates to the social determinants of health? I was, as you were describing those, I thought we can really learn a lot about this and how it relates to social determinants of health in our country.
Mm-hmm. Yeah, absolutely. And it's a much bigger conversation that I'll try and answer quickly, but health doesn't start when somebody starts in prison. Somebody's access to healthcare might start when they start in prison. And so when we're thinking about these social determinants of health that we think about in all of the communities that we work with, they are still relevant to these individuals who are incarcerated, oftentimes to a really stark, really high degree. And so when we're thinking about our population of people who are incarcerated, they're oftentimes subjected to like influence of systemic racism, influences of low income or of poverty, influences of inadequate healthcare, mental health care. And so when we're thinking about all of these social determinants of health that we think about with our community population and with our population health, the same social determinants of health are still impacting these individuals when they're incarcerated, because again, health does not start nor stop when somebody enters or leaves the prison system. And so it is exciting that incarceration is being identified as a social determinant of health, as its unique own influencer of health. But it is important, to your point, to remember that it's happening within this larger holistic context of health and well-being.
Yeah, well, thank you for your response to that. So Susan Loeb says familiarity with those corrections officers overseeing that consistency can be very important to identifying changes and risk. Number one, are there barriers to maintaining that familiarity or consistency? And two, are there any risks to having the same COs oversee the same group of people who are incarcerated over an extended period of time?
Absolutely. Thank you for that question. So the barriers to having that consistency or to kind of developing that familiarity, one of the leading barriers is, of course, staff turnover. And that correctional officers, it tends to be a pretty, high turnover, high movement population. And some of that is built in because of, related to the second question, are there risks to having somebody that develops maybe too much familiarity, and this constant and pervasive risk of fraternization or inappropriate relationships between the correctional officers and the individuals who are incarcerated. So some institutions have where a CO can only work on a housing unit for a set amount of time, 6 months, 6 weeks, whatever, what have you, and then they have to rotate in order to not develop these really strong relationships, because they can be a risk of fraternization or something more negative, in consequence. So it definitely is a balancing act of, from a health perspective, we would love for all of our officers to know our incarcerated folks really super well. But again, we're working inside of a prison, and we're working in this context of corrections and security. And so we need to make sure that we're being cognizant of all of the potential risk and fallout from that.
It certainly is a very unique context. And thank you so much for sharing all of your expertise and this fascinating study. We learned a lot today. I know I certainly did. And there's so much more to explore, I think, in terms of education, clinical practice, and future research. So congratulations on this particular study, and we look forward to learning more about what where your research goes from here.
Thank you.
So
And
thank
I know
you again.
my email is on the slides. Dr. Loeb also has my email. Jenny also has my email. So I'm happy to entertain any questions outside of this, as they come up.
Well, thank you so much, Kristen, and thank you
Thank you.
for your time. Thanks to all the participants for coming today, and I hope you have a great rest of your day.
Thank you.